In the last 10 years in this country, in the UK certainly, life expectancy has stalled. And in the last few years, we've seen an increase, certainly in many parts of the country, of unhealthy life expectancy. So people are now living longer in poor health and total life expectancy has stalled. So we are regressing now. The problem is that most research now, which is sponsored by the drug companies, the conclusions are essentially exaggerating the benefits and the safety of many drugs, you see. If this was widespread in discussions, there'd be a massive reduction in medication uptake. And of course, that's going to hit the profits of an industry that's got more power than many governments across the world, and that's Big Pharma.
Yeah.
Let's look at all of the drug trials, industry-sponsored trials, to see whether there was any clear correlation with lowering cholesterol in both people at low risk of heart disease and high risk with preventing heart attacks and strokes. There was none. A state of complete mental, physical and social well-being, not merely the absence of disease and infirmity. So we talk about health. If we understand that definition, we can then branch off into the root causes, because what does social well-being actually mean? Social well-being is not going to be improved by giving people pills. Heart disease is, 80% of heart disease is certainly related to lifestyle and environment, and therefore the solutions are to focus on those. Prevention is better than cure, but even in management of these patients, the lifestyle intervention often is at the root cause of the problem that brought them in the first place. And that's really where we're at.
Hello and welcome to the CNM Specialist Podcast with me, Bobby Qureshi, CNM's Director of Education. Today, I'm absolutely delighted to welcome Dr Aseem Malhotra. Dr Malhotra is a consultant cardiologist and world-renowned expert in the prevention, diagnosis and management of heart disease. He is a public health campaigner, best-selling author and an international guest editor for the Journal of Evidence-Based Healthcare. He has won a number of awards for his work to raise awareness about the role of diet in chronic illness, both in the UK and internationally, and has been listed as one of the Sunday Times 500 most influential people. Thank you so much for joining me today, Dr. Malhotra. I'm so glad to be speaking with you on some very important topics.
Pleasure to be here, Bobby. Thank you for having me.
You've obviously developed a little bit of a name for yourself now as a campaigner in the field of healthcare. You very much are a big advocate for the importance of diet and lifestyle. But of course, you first trained as a cardiologist. So how did you sort of transition and what triggered that change in your direction?
Yeah, it's a great question. So, Bobby, I qualified in 2001 from Edinburgh Medical School. So I've been a qualified doctor now for over 20 years. And I subspecialized in cardiology and trained in interventional cardiology, which in layman's terms is keyhole heart surgery. And then I gradually then shifted more of my attention to prevention because I think that's what we need to be focusing on more. For me, on a personal level, I have always wanted to aspire to be the best possible doctor I can be. And to do that as a doctor, I always refer to a great analytical framework for teaching and practicing medicine, which is using your clinical expertise and knowledge, the best available evidence on a particular intervention or drug or even lifestyle intervention. And then last but not least is taking into consideration patient preferences and values, and for the purpose of improving their outcomes, which is treating illness, relieving suffering, and managing risks. And what I found, to answer your question more directly, over my career, I was seeing more and more stress on the healthcare system, more and more stress on the NHS in terms of patients coming in with more and more conditions, certainly related to lifestyle, and not really getting better. We were throwing lots of pills at people. And I could feel that if we carried down this trajectory, and I kind of started as an activist or campaigner in this field through writing, probably towards the end of 2008, 2009, 2010. I myself, my own observations, felt that if we didn't tackle things head on and start to tackle things head on then the NHS would be in a position where it wouldn't be able to cope even with basic quality care. And that's where we're at right now, sadly. So for me, I decided then that once I'd identified the root cause of the problem, I was going to do my bit to disseminate knowledge around it and call for policy changes as well to help reduce the burden of chronic disease on the population, which has only got worse. So just to give some data and perspective to people, in the last 10 years in this country, in the UK certainly, life expectancy has stalled. And in the last few years, we've seen an increase, certainly in many parts of the country, of unhealthy life expectancy. So people are now living longer in poor health, and total life expectancy has stalled. So we are regressing now. Our health is getting worse. So this is because we haven't tackled prevention properly. And also linked to that is over-medication. So prescribing drugs to patients that will only get marginal benefits without explaining that to them, distracting from lifestyle as well. When you combine it together, you create a recipe for suboptimal patient outcomes. And then if you take a step back, which is what I did, so it's not just about what's going on in the consultation room, it's looking at the causes of the causes. So what really determines our health are actually what we call the social determinants of health, which are the conditions in which we're born, grow, live, and work. And that all links in through things like chronic stress, lifestyle behaviors, and addressing those at the root is going to have the biggest impact in the long term for everybody in terms of improving health.
Yeah. And I think because now we are seeing higher rates of chronic disease than we've ever seen before, like you said, the quality of life is declining.
Yeah.
There are so many questions to be asked, and simply people aren't really getting answers from conventional medicine typically. And I think this is where people like yourself who are trying to sort of highlight the importance of looking at the cause. It's just so crucial what you're doing.
Yeah, absolutely, Bobby. And you raise a good point there, because I think there is also still a myth out there about the what modern medicine can achieve. And just to give an example of a better understanding of the limitations, if you like, of modern medicine. So if you look at our increase in life expectancy in the last 150 years plus, so since 1850 to now, we've added about 40 years on average to our life expectancy. And a survey was carried out in America of educated adults, asking them how much of those 40 years did they think modern medicine had contributed. And the response was, on average, people thought 80%. So 32 of those 40 years was because of modern medicine, when nothing could be further from the truth. In fact, it was at best probably 3.5 to 5 years. Most of what's increased our life expectancy have been through public health interventions, things like safe drinking water, seatbelts in cars, safer working environments, smoke-free buildings. As a cardiologist, I will tell you that the biggest single impact, or the most important intervention on reduction of death rates from heart disease in the last 3 decades has been the taxation of cigarettes, reduction in smoking, tobacco control. And many people forget that. I knew this early on, even as a cardiologist doing ward rounds and treating people for heart attacks and, going around on the ward. And one of the things I would tell my patients is that, especially in particularly the smokers, many of the people coming with heart attacks are still smokers. I would say that you stopping smoking is more powerful than all the medications, cocktail medications we're giving you combined. So that's what you need to focus on. And these medications will have an incremental benefit, but really it's about lifestyle.
And it's interesting with smoking because, of course, going back many decades, smoking cigarettes was actively promoted. And of course, it was promoted as being the good thing to do, the cool thing to do. And then obviously we're seeing the health effects of those and the relationship to disease down the line. And I suppose it does raise some questions about perhaps what's happening at the moment, what's been happening more recently.
Yeah, no, absolutely. So, in terms of smoking, doctors at one stage were promoting smoking. They thought it might be helpful for asthma, for example. Wow. Doctors used to be involved in advertisements for cigarettes. So what does that highlight? Well, it highlights that, first of all, medicine is not an exact science, say like physics or chemistry. I'd say it's an applied science using the art of probabilities based upon information that's available at the time. And one of the founding fathers of the evidence-based medicine movement, something I preach and advocate for, David Sackett, he said half of what you learn in medical school will turn out to be either outdated or dead wrong within 5 years of your graduation.
Wow. The
trouble is nobody can tell you which half, so you have to learn on your own. I think that's a really important concept for everybody to understand, especially doctors, because it then keeps them open-minded to changing information rather than a scientific determinism where they think this is an absolute truth and therefore anything that contradicts it cannot be true. And actually that's part of being a good doctor. When you have conversations with patients, you always say there is an element of uncertainty with a lot of these things. But right now, this is what I think is best for you. And patients appreciate that. They want that honesty. Yeah,
of course. And you mentioned there evidence-based medicine. This is, I think, a really interesting area. Could you just explain to our listeners a little bit more about how that kind of fits into the dynamics of, the medical profession?
So David Sackett himself actually developed this triad, which I'd mentioned earlier, called the evidence-based medicine triad. So using your individual clinical expertise and experience, best available evidence, and patient preferences and values. And it may sound obvious, but in many ways it isn't being adhered to, not in a deliberate way, but if you accept that this triad is the best way to improve patient outcomes, anything that interferes with that, so say the doctor himself hasn't got the right knowledge or isn't taking a good history to get the diagnosis, or the best available evidence has been manipulated, or patients aren't actually being listened to in terms of their values and preferences, or informed consent in particular isn't taking place, which I'll talk about in a minute, then you're either going to get suboptimal outcomes at best, or at worst cause harm. And actually that's the situation we're in. So according to best available evidence, I always cite somebody I have great admiration and respect for in terms of his scientific integrity. I've described him as being a Stephen Hawking-like figure in medicine. So he's the most cited medical scientist in the world, professor of medicine and statistics at Stanford. His name's John Ioannidis. And he wrote a paper many years ago where the conclusions were why most published research findings are false. The problem is that most research now, which is sponsored by drug companies, the conclusions are essentially exaggerating the benefits and the safety of many drugs, you see. So when you break it down, he concludes that most published research findings are false. And he says the greater the financial prejudices in a given field, the less likely the research findings are to be true. So the problem we've got is that evidence-based medicine has been hijacked by vested interests. And there are a number of factors that play into that. And the problem with that is if you as a doctor are making clinical decisions on biased and commercially corrupted information, it doesn't take a rocket scientist to work out that's going to give bad outcomes to your patients, and that's what we've got.
Right. Okay. So it's quite scary, actually, when you really start thinking about it. And of course, people talk about the role of big pharma and the pharmaceutical industry, but we're seeing it play out right in front of our eyes, aren't we?
We are. And I think the reason it's not being addressed, Bobby, is because most people don't know this. Most doctors don't know this. They're not aware that a lot of the research that they rely on to make decisions is either poor quality or has been manipulated.
And why is that? Why do you think they're not aware of that?
Well, it's because those vested interests that profit from that misinformation, i.e. big pharma, for example, are able through their power and through invisible power to define the dominant narrative and suppress information which gets out into the mainstream that tells doctors and the public that actually this information is biased and corrupted.
Right. Okay.
So there's a great line by Noam Chomsky, the American philosopher, and he says that, and I'm going to paraphrase him actually. So the general population, doctors, patients, and the public don't know what's happening, and they don't even know that they don't know.
I think you just summed up the issue right there. Yeah. And that's the problem, because if obviously people will look up to their doctors with great admiration, great respect, and they'll be looking for the answers from them. And of course, if they're not aware that they don't know, then of course it's filtering down to our patients. And you made a really good point before about informed consent. I mean, my first degree was in osteopathy, and I always remember when I did my degree, we were always told, get your patients informed consent, tell them the benefits, tell them the potential risks, make sure that you've got their informed consent before you do any technique at all. And of course, you've spoken about this here as being a crucial element to the medical profession, but are patients being given the opportunity to give informed consent?
So I think when we talk about informed consent, at the heart of informed consent with decision making is transparent communication of risk and benefit of anything, whether it's surgical procedure or whether it's a drug that's being prescribed. But the reality is, and this is through my own experience, this is through my own publications of being an advocate, is in many cases, if not most cases, it's not actually happening in the way it should. And I'll elaborate a little bit more by giving an example of use of a cholesterol-lowering drug or one for heart disease called statins in a second. Without understanding the numbers involved, the public, and even doctors to some degree, are vulnerable to exploitation by commercial and political interests. Okay, so if we take the statins, for example, so this is a cholesterol-lowering drug, one of the most lucrative drugs in the history of medicine. It's a $1 trillion industry. And the reality is, when you break down the data, even from industry-sponsored trials on statins, because most of this information comes from drug company-sponsored trials, so it's likely an exaggeration, but even if we take that as gospel truth, if you are at, say, low risk of heart disease, i.e. you've not had a heart attack, then the chances of a statin benefiting you over a 5-year period, based upon the trials that showed those benefits on an individual level, are about 1%, 1 in 100. So what I would say to my patients, if I'm having a conversation with them about statins, for example, is I would say, listen, if you take this drug religiously every day for the next 5 years, there's a 1% chance it's going to prevent you having a heart attack or stroke, but it will not prolong your life by 1 day, because that isn't shown to be beneficial for mortality in low-risk people. If you are high risk, in particular you've had a heart attack, or you've had a stent put in or a severe blockage diagnosed, then that benefit increases to about 1 in 39 in preventing a further heart attack or a non-fatal heart attack, and 1 in 83 for mortality, in terms of the 1 in 83 chance. This is what we call absolute risk reduction. That is exactly the way we should be telling patients about any intervention. And every patient's going to react differently. Some of them are going to say, I don't really fancy that, doc. Is there anything else I can do? And that's where you can come and talk about lifestyle, for example. Some will say, you know what, I don't mind taking that chance. And that's what we should really be doing with patients, is giving them that information in that way that's understandable.
Yeah.
Okay. These are basic numbers that most people can understand. And then, accepting that decision and supporting them in their decision. And that's my approach to patients.
Yeah.
And it's not just something I advocate for. In 2009, the World Health Organization put a bulletin out, and it was authored by the man who's considered the leading person in the world in health and statistical literacy, Gerd Gigerenzer, from the Max Planck Institute in Berlin. Very eminent professor in statistics. And he said it's an ethical imperative for every doctor and patient to understand the difference between relative and absolute risks to protect patients from unnecessary anxiety and manipulation. It was reinforced in 2015 by the Medical Royal Colleges, which is the organization that represents every doctor in the UK, in a paper that I was the lead author on, with the chair of the GMC at the time, where we basically reiterated that as well.
Right.
Now, there's one thing having the knowledge and the arguments behind that and the ethical considerations behind that, and there's another thing, making sure that it's widely implemented. And it hasn't been enforced in a way, and that's partly because there needs to be an education behind it as well. Most doctors are not taught in this way.
Yeah.
Okay, so that's something that needs to happen through medical school and postgraduate medical education. But I think that there's a lot of barriers to implementing this, because I think, obviously, if this was widespread in discussions, there'd be a massive reduction in medication uptake. And of course, that's going to hit the profits of an industry that's got more power than many governments across the world, and that's Big Pharma.
Yeah. And do you think...
So we can't be naive to that.
Of course. And I think you're absolutely right to highlight this as a big issue. Whenever we teach students just at CNM to evaluate research, we always say, look at who's funded the study, look at where the studies come from.
Yes.
Which is a good place to start. You mentioned relative and absolute risk there. Is this how statistics can be manipulated?
Yeah. So, for example, if you've got a randomized trial, which is the highest quality evidence to try and show the benefit of an intervention. Let's say you have 1,000 people who followed up over several years to look at stroke. How many strokes are going to happen? And let's say 2 of 1,000 people had a stroke, okay, in the people that were on the placebo drug, the dummy pill. And then the people taking, let's say, for example, statin, right? So the people taking a statin, of those 1,000, similar group of people who were on the statin, only 1 in 1,000 of those people had a stroke, right? So what you've done is the relative risk reduction is you've reduced the risk from 2 in 1,000 to 1 in 1,000. That's a 50% relatively less likely to have a stroke. But the absolute risk reduction, the real, for the individual, is you've only reduced 1 stroke out of 1,000 people.
Wow.
So you've reduced the risk by actually the absolute benefit is 1 in 1,000.
Wow.
Or 0.1%. And that is actually what's been going on over the years is that people have been given information in relative risk terms, not absolute risk terms. And you can use both, but you have to make sure the patient understands the absolute risk so that they are not misled in terms of exaggerated benefits.
And is that taught in medical school, the difference? No. Okay.
No, not really. I mean, it's taught it's kind of probably there somewhere, but it's not something that's considered mandatory in terms of what should be happening in medical school. Is we should be, examinations should be breaking that stuff down, and then it should also then be translated. So when you have a conversation with a patient, when that information is available, you must share that information with the patient, and you must then accept their decision. And that doesn't happen. That's not part of medical training. And certainly I wasn't taught in medical school this stuff.
Interesting. Okay. And this idea of how statistics have been manipulated or can be manipulated, and this idea of relative absolute risk, just looking at what's going on now in terms of the COVID vaccine data that we've got, is this something that's relevant here as well?
Yeah, it's a great question. So I think just to give you a background, I was, I took, 2 jabs of the Pfizer vaccine very early on. I helped out in a vaccine center. As you probably know, I've been someone that's been an advocate for greater transparency in medicine for many years, and in some ways a critic of the excesses and manipulations of the drug industry. I was not concerned at the very beginning at all about any safety issues with the COVID-19 vaccines, and that's because I had conflated vaccines with traditional vaccines. And if you look at all the drugs that we have used in the last few decades in medicine, vaccines by far the safest. So I didn't have any concerns at the time. I was a little bit unsure about what the efficacy would be. But anyway, I took the vaccine not because I felt that I was at particular risk, but because I thought I was going to protect my patients from getting COVID if I was at reduced, wasn't getting infected.
Yeah.
And of course, the information has evolved since then. I think what's crucial to answer your question is, once we have accepted, and I think most people have accepted now, certainly with new variants, that the vaccine isn't preventing transmission, it then becomes an issue of what's your individual risk and benefit. Because you're not helping anybody else. You're not saving grandma. You're not saving anybody else if you're having the vaccine. That's quite clear now. The evidence is quite clear on that. So therefore, the decision should be then be an individual. It should be an individual one anyway, but I think that the argument that you're protecting other people has gone out the window. So then what is your individual benefit in absolute terms? So that hasn't been fully elucidated yet in terms of individual benefit. Yeah. But what has concerned me recently is new researchers, credible research published in, the most recent one was a couple of days ago, published in the Journal of Vaccine. And some independent researchers were able to get access to the original trial data that led to the rollout of Moderna and Pfizer vaccines. And what they found was that in the trial, it appeared that the risk of a serious adverse event, so life-changing event, disability, hospitalization, for example, from the mRNA vaccines, Pfizer and Moderna vaccines, appeared to be significantly higher than the risk of being hospitalized with COVID. Now, that in itself is pretty extraordinary if you think about it. So the question then is, well, where do we go from here? Well, there's still missing information. So this is an average across many age groups. Is it same for everybody, an 8-year-old versus someone who's 20 years old? It's probably going to be different. And what I've called for is the raw data to be released from and independently analyzed from those trials, because what's happened is, what many people don't know is that a lot of drug approval happens from summaries of information that's given by the drug company of their trials.
Oh, I see.
And the regulator in some ways, doesn't always have all the data and relies on what the drug company give them to then approve a drug. So, and the other issue, which is a big problem, Bobby, as well, is, and this needs to change, is that many of these regulators, including our regulator in this country and the FDA, get most of their funding from the drug industry as well, which is a huge conflict of interest.
Massively.
And money, it doesn't mean those people are deliberately, approving drugs through any ill will or because of money, but what happens is money clouds judgment and it adds a bias. And I think that with the history of the fact that prescribed drugs now are a big problem in terms of their side effects, estimated to be the 3rd most common cause of death after heart disease and cancer, I think people need to be asking questions, how have we got to this situation, and what are the root causes behind it, and what can we do to change it for the future so that we get information that we can trust.
Yeah, absolutely. And that's all people want, right? People want transparent information. Yeah. They want to know the truth. And obviously it's difficult for people because when they do sort of raise concerns. A lot of people then get labeled as certain things, which maybe isn't true, but just like yourself, trying to critically evaluate the data that we have, the information that we have, so that people can make, again, an informed decision, coming back to that same point.
Absolutely.
So right now, we don't have the data. Say, for example, the Pfizer trial, we don't have the data available to us. Is that correct?
We don't have the complete data to be independently looked at to see, yes, exactly, what's the benefit and harm ratio. So I think people are increasingly accepting now that vaccine side effects and serious ones are a real issue. We saw that with the AstraZeneca vaccine, for example. I mean, that basically got pulled. We don't use that anymore because of the clotting issues and the heart attack issues in particular were really unprecedented in their scale. So we stopped using it in this country. They never used it in the US. And I think that's an example, of course, that this is something that we weren't prepared for. People, I suppose, have accepted and been under the impression, well, okay, so these side effects are relatively rare, which is not necessarily true. But they think the benefits of vaccines are very strong. So I think the bit missing from the equation is really some kind of analysis, which I'm working on at the moment, to try and actually break down for individuals what is the benefit, for example, of the vaccine preventing you dying from COVID.
Yeah.
And we're almost there. One thing I would say, which is a reassuring comment, is that although there's no doubt COVID was devastating initially, and particularly for vulnerable groups and the elderly, it was devastating. It was awful. I know people that have died from COVID that otherwise would have probably survived if COVID wasn't around at all. Is what's circulating now, thankfully, the Omicron variant has been compared to being as lethal only as the flu. We didn't go around scaring people to death about the flu. We need to stop, in my view, scaring people now about COVID.
Yeah, I couldn't agree more. Could not agree more. And of course, when you scare people, that's not exactly the best thing for their health generally. And of course, it induces huge amounts of stress. And obviously, we saw probably that playing a factor, although we don't know quite the impact that will have had of people being scared for various reasons.
And actually, even coming down to basic principles of medical practice, one of the most important things we do as doctors is to alleviate people's fears and anxieties. That's a really important skill, and that's much of our practice is that. And we shouldn't be contributing to that wittingly or unwittingly.
Of course. You mentioned before as well about some of the side effects, which we do know, for example, high risk of clotting issues. Just obviously thinking about that from your perspective with your expertise, just zooming in there a little bit. Do we know how that works? I mean, obviously, just in fairly simple terms, do we know the connection?
Yeah, so it's a great question. It's not fully understood. There are different hypotheses out there, but certainly if you look at the mRNA products, the platform that's used and the spike protein appears, there is some evidence to suggest that it gets distributed throughout the body. Not for, if it was just staying in your arm, causing a bruise for a couple of days and generating antibodies, it wouldn't be a big problem. But it appears that it can stay for several weeks to months in different organ systems. And that is likely the mechanism of where the harm is coming from. What we need more precision on is exactly, in that informed decision-making process is what's your absolute benefit? And it may be, in some ways it can be comparing apples and oranges because, I'm sure that the prevention of COVID death from the vaccine is likely to be much smaller or better, greater, if you like, as a benefit than the harm of dying from the vaccine. Of course, people have died. But we need precision on that. But I think there are a lot of problems in relation to non-mortality harms, right? Heart attack, strokes, disability. And I think that conversation needs to be had with patients, and then we support their decision on it. But if there is a level of significant harm, and let's say, for example, it is 1 in 800 or 1 in 1,000 of serious adverse effects, it's not small when you're distributing and certainly many people have been coerced into this across the world.
Yeah.
That's a massive problem because you're going to create, if you're giving it to millions, tens of millions, billions of people, you're going to cause a lot of harm. And I think because Omicron and what's circulating now is no worse than the flu, we can have that conversation in a way that won't scare people as such and will not cause so much harm by, if that was to get out and saying this is a problem and people say we're not going to take the vaccine, the harm done is much less. Yeah. But we have to have an open, honest conversation about it. And that hasn't really happened yet.
I agree. And part of the reason that it probably hasn't is censorship. Of course, you know, to have any different view from the main narrative was, you know, certainly, I don't know if you agree, but it feels like it's not quite as intense now, but certainly going back through the main part of when COVID was a real issue and we were in lockdowns, etc. I mean, other opinions just weren't really allowed, which is scary. I think you've raised some really good points. And I think the key message here is, of course, transparency. We all need to have an open conversation. We need to be transparent with data, understanding the potential risks, having those conversations with patients so that they're informed. So thank you for being very open and explaining that. One thing I did want to talk to you about is heart disease, cardiovascular disease.
Sure.
Of course, this is something you're very renowned for. Just to start with, could you just explain to our listeners what we actually mean by cardiovascular disease?
Yeah, so really it's any disease that affects the systems that involve the circulation. So heart, blood vessels, brain, essentially. But it can also apply to things like kidneys and the peripheral vascular system, so blood supply to the lower limbs. And the risk factors for those are essentially all the same. The traditional ones that we learn in medical school are high blood pressure, type 2 diabetes, smoking, and what we call dyslipidemia, or an abnormal cholesterol profile. Although some people still think it to be high cholesterol.
Okay.
But what I've done over the years is trying to understand, is there anything that brings them all together? And the evidence has evolved on this, and certainly that's something I've published on. And it's accepted broadly that the most important sort of risk factor, if you like, for development of heart disease is something called insulin resistance, combined with chronic inflammation, which is kind of a generic inflammation in the body that causes damage to the inner lining of the heart arteries. Insulin resistance is essentially your body, the cells of your body, becoming resistant to the hormone insulin, which is released by the pancreas and has many roles, including fat metabolism. And what leads to that, and therefore drives high blood pressure and type 2 diabetes, and an abnormal or an inflammatory cholesterol profile, is either anything that causes insulin to be chronically raised over a period of time, and that comes from diet stuff. So very simple terms, it's high glycemic index carbohydrates, things like sugar, that kind of thing, and then being sedentary. You know, if you're active, that makes you more insulin sensitive, so that counteracts insulin resistance. And then one of the missing links, I think, Bobby, that isn't getting as much attention as it deserves, but I know in CNM you probably talk about this a lot, is chronic psychological stress. And that also contributes to insulin resistance and chronic inflammation, increases clotting factors in the blood. So what I've done is bring it all together, and I've written about this extensively. But the solutions are not rocket science. They all come down to lifestyle. And it's kind of well established that heart disease is, 80% of heart disease is certainly related to lifestyle and environment. And therefore the solutions are to focus on those rather than medications. Medications have a role, of course, but prevention is better than cure. But even in management of these patients, the lifestyle intervention often, which is addressed, is the root cause of the problem that brought them in the first place, can be very useful in managing those patients further on, even potentially reversing heart disease. And that's my area of interest as well. And that's really where we're at.
And what's interesting is that you explained the big causes of heart disease, but you didn't really mention cholesterol, which of course for so many years has been sort of put forward as the big reason people get heart disease. And quite frankly, most people are terrified of the word cholesterol. They will go and get their bloods tested and they come back and they're scared about what their cholesterol might mean, and they've been put on statins, etc. So this whole background to cholesterol, could you sort of explain, where did this all begin? Where did this obsession and fear with cholesterol come from?
So the fear, Bobby, came from the fact that from 1920, really the obsession or concern with heart disease started in 1920s and then built up certainly to the 1950s, 60s, 1970s. So the death rates from heart disease started to increase, and scientists and doctors were wondering what's going on, what's causing this. And by the way, it wasn't until certainly, I would say at least the late 60s, early 70s, where there was a broader, even later than that, an acceptance of the impact of smoking, because the tobacco industry were very good at suppressing information that allowed doctors and the public to understand that actually smoking was a big factor in that. So imagine doctors are trying to figure out what's going on. And then a number of studies were carried out. One of the most famous ones is called the Framingham Heart Study. And that started in 1948 in in Framingham, Massachusetts in the United States, and followed up 5,000 people, young and middle-aged, and over a 30-year period to try and work out what were risk factors for heart disease. And from Framingham, we figured out high blood pressure was a problem, type 2 diabetes, for example, and also high cholesterol. But the people in Framingham where there was a development of high cholesterol associated with heart disease was actually at the extreme end. So we call this familial hyperlipidemia now, which affects about 1 in 250 people, and is genetically very, very high levels of cholesterol. What they found in Framingham, though, which is interesting, is that people where there was very, very high levels of cholesterol, there was a strong association with heart disease, premature heart disease.
Right.
But also people at the very lower end didn't tend to get heart disease. So people with genetically very low cholesterol, which is only about 5% of the population. But for the overwhelming majority of people, it wasn't a useful determinant, okay? And it was felt and thought, okay, there must be a linear association. And because people with very low cholesterol, which is predominantly genetically determined, by the way, didn't develop heart disease, therefore lowering it must be the solution. And then lots of trials and drug trials and dietary trials started taking place, and it became almost a gospel truth without that definitive answer that would lowering cholesterol make any difference. We fast forward to where we are now, and I actually co-authored a paper a couple of years ago in BMJ Evidence-Based Medicine with 2 cardiologists, where we decided let's look at all of the drug trials, industry-sponsored trials, to see whether there was any clear correlation with lowering cholesterol in both people at low risk of heart disease and high risk with preventing heart attacks and strokes. There was none.
Wow.
So even though there was my how I'm trying to explain this is that these are markers of maybe heart disease development, but on themselves may not be the cause. There may be something else going on. So if you look at people with FH as well, with genetically very high levels of cholesterol, so this would be an LDL of at least 4.9 millimoles per litre. Okay,
and LDL, just to explain,
is a so-called bad cholesterol, okay, low-density lipoprotein.
Yeah.
But it isn't that bad, as people think, because certainly cholesterol has many roles in the body, right? And one of them is thought to be in the immune system. And people with low levels of cholesterol, there is an association with cancer and with development of things like infections like pneumonia. So there's an issue there. But even people with familial hyperlipidemia, who tend to be more at risk of developing heart disease prematurely, even when you look at those patients, the ones that develop heart disease versus the ones that don't, because many of them actually live normal, healthy lives without treatment, even though their cholesterols are through the roof and don't get heart disease, there's no difference between the LDL levels in the people with heart disease and the people that got it and people that didn't, which suggests there's something else going on. Yeah. And we think that the people that tend to develop heart disease are people who may have something else in the blood with abnormal clotting factors, for example. So this is what we're trying to change the understanding so we can be more precise in treating the right patient with the right drug at the right time, or the diet or the lifestyle intervention. But irrespective of medications, one thing we can advocate for everybody is saying, listen, if we focus on the lifestyle stuff, you are going to be dramatically reducing your risk anyway of heart disease. And that's where I talk about, a low carbohydrate, low ultra processed food diet, moderate activity, stress reduction, meditation, making sure, having a good social structure, concentrating on meaningful relationships, spending time with people that increase your emotional sense of well-being. These are actually at the heart of actually leading a healthy life, both from a mental health perspective and physical health perspective.
And it's so nice to focus the conversation on practical solutions that people can put into their lives rather than focusing on cholesterol and focusing on LDLs and focusing on, all of that, basically this idea of fat building up in your arteries, which I think people, that's what they envisage, right? In their heads, it's sort of like, if I eat fat, I'm going to put fat in my arteries. I think that's what some people literally connect in terms of the dots.
Absolutely. And we know that's completely false. So, there is no clear evidence now that eating fat is going to clog your arteries. Absolutely not. I mean, okay, some of the stuff that's kind of not being used so much, like deep frying in omega-6 seed oils, for example, are not good. But saturated fat in things like red meat, dairy, for example, there's no relationship between the consumption of that and heart disease. In fact, there is a slight association, a correlation with dairy fats and reduction in heart disease now.
Wow.
So it's all been turned on its head.
And what we're saying is the real problem's the sugar. It's not the fat. It's the big issue underpinning this issue.
And I think in the population, ultra-processed food. So just to define it for people, what I tell my patients in a very simple way, if it comes out of a packet, has 5 or more ingredients, usually with additives and preservatives. Don't eat it, it's ultra processed. And those foods have been engineered by the food industry to be, they're cheap ingredients, highly profitable. What they do is they combine, they're food engineers that combine, sugars and carbs and fats together to make them very palatable, probably addictive to some degree, huge profit margins. But what they do over time is they increase weight gain, inflammation in the body, and ultimately will damage your health.
Makes complete sense. Another industry we need to be a little bit careful of. We've spoken actually on other podcasts about being really mindful of looking at marketing on food, making sure that, something might be marketed as heart healthy, let's just say, or good for your cholesterol, but obviously doesn't, we're looking at the bigger picture.
Often if it's marketed as healthy, it's the complete opposite. So there's very good information from what we call corporate playbooks of food industry and even tobacco, is to distract actually sometimes from unhealthy products, they will deliberately market it as healthy. It's extraordinary, isn't it? Absolutely extraordinary.
And it's right in front of your eyes.
Yeah.
And then I guess you wouldn't really think it if it's written as healthy. Why would you question that?
Exactly. So what we need to do, Bobby, really is to protect the public, because you can exercise personal responsibility to only a certain level, because to exercise personal responsibility, you need to have the correct information, knowledge. You need to have choice. It needs to be accessible to you, talking about healthy food, for example, and affordable. And many people don't have any of those. And therefore, you can't even have a conversation about it. In fact, it's insulting to talk about personal responsibility. So let's go to the root cause and address the legal entity, if you like. That is the corporation that is there purely to make profit and will lie for profit, will deceive people. People don't know this stuff, and the regulations are weak, and they capture politicians, they capture regulatory bodies, and ultimately the population suffers. And we just need to be more honest and open and transparent about what's really going on, because if we don't, we're seeing what's going on right now. Society is regressing, it's becoming more unhealthy, people's mental health is getting worse. And, to paraphrase the clinical psychologist Jordan Peterson, what we need to speak the truth. People need to know the truth to save the world from hell.
Yeah, I couldn't agree more. That's so well said. And I think, this is ultimately why people like yourself, Aseem, and other people in your profession who are really looking very critically at the whole situation, at data, trying to make this available for people. Because I think that's one thing that the general public, they want this to be accessible. They won't be able to read a research paper like you will and be able to pull it apart, whereas you're skilled in your ability to do that. So I think people want that information to be accessible and, of course, not to be censored at the same time. So it does reach, their laps.
Absolutely. And I think part of the skill as well, I think for everybody though, is certainly for doctors, something we need to focus on, is translating and communicating information in a way that person can understand. And you have to vary it as a doctor depending on who you're speaking to. And that's a really important skill, I think, for all of us to think about. When we become aware of something, if we come from a position of wanting to speak the truth, wanting to know the truth, hating injustice, we all actually have a role to play in being able to use those values to have maximum impact for the people around us. One of the things I think we need to think about as well is society has drifted very much, and partly because of this corporate machine that has manipulated in many ways to get us to this state that we're in, is we've become more and more individualistic, and human beings don't function well in isolation. We function better in communities where we've got people around us through solidarity, through meaningful relationships. So we all have to think a little bit more that if we focus on helping others, we are actually helping ourselves. Yeah. What's happening now is people are focusing too much on helping themselves, and therefore it damages solidarity, it damages trust, and ultimately it's damaging to us. Yeah. Because it's not what it means to be human.
Yeah. And we saw that during lockdowns, didn't we? We saw the impact of lockdowns, the very negative impact, which quite frankly didn't get spoken about enough certainly in the media anyway. Yeah. When we're isolated, we saw the effects, particularly on mental health. And, I think I read a statistic the other day that now one of the biggest groups in terms of those that are isolated is men in their 30s. I mean, it's unbelievable. And this just happens to be the age group where we're seeing unbelievable rates of suicide. We're seeing, mental health problems in unbelievable levels like we've never seen before. We've got so many excess deaths, of course, which are being reported now constantly. And of course, we don't know exactly what the reason is for that, but it does make you question that. And I think the point about isolation is it's not just elderly people who have maybe lost a partner and are at home on their own. This is people, our age that are genuinely lonely, that aren't getting social interaction. And the effects of that, as you've highlighted, could be pretty catastrophic.
Absolutely. We're seeing it already, Bobby, for sure. I think even lockdowns themselves weren't based upon high quality evidence. There was no consideration, even though many people were speaking out at the time, respected doctors, about the harms to children's education, for example, and all the economic impact of it. So it's important to learn from history. We need to try and turn it into something positive. This could easily go down what I fear, the wrong route, where when the truth finally comes out on many of these issues, it could create a lot of division and hostility. And we have to think, hold on a minute, no, okay, we need to make sure we utilize this information in a way that actually is constructive for everybody, moving forward in a positive way. And that means being compassionate towards people that may have disagreed with us or disagree with, on many issues, because division and hostility is actually sending the world to a very, very dark place. We see that all the time now. So we need to build bridges between people from different backgrounds, different political aspirations. And unless we do that, the solutions and the consequences of the dissemination of the truth, which I think we're increasingly getting to that point where people are becoming more aware that they've been misled by powerful vested interests, could take us down a very dark place. And we have to be prepared to be aware of that. And certainly I'm somebody that is there to build bridges and not to point fingers and to blame people. And you can learn from history, people like, for example, Nelson Mandela. He was locked up in 27 years in prison, and a lot of atrocities were committed by the South African government towards black people over many years. And it could have turned very nasty when he became president, because there could have been, revenge attacks and that kind of thing. And he was coming out and he said, no, we have to forgive and we have to learn and move forward. We need to remember those sorts of historical moments and how important they were, even when this situation erupts. Because, say, for example, being hypothetical here, but let's say, for example, when we get the raw data on the vaccine and it turns out that for many people, maybe most people, ultimately the vaccine was more harmful than beneficial, and people are going to realize, for example, that Uncle Bob or their mum or their dad or whatever, who was coerced in taking the vaccine, died because of it, it could get very, very, there could be a lot of anger, understandably. And it potentially, and this is what I don't want, and I'm not, but this is my fear, is, we're a world of 7 billion people. We can't control everyone and everything, but it could get violent. And we don't want that to happen. So we need to understand, okay, this is why the situation happened, when whatever they say the vaccine was rolled out, and understand the root cause of it, and then move forward in a constructive way.
I think the point about compassion is really, really important. I think you've highlighted there is a lot of division. We saw that going back to Brexit. There's a lot of division. We saw that with COVID. There was a lot of division. There will likely be more division, as you've highlighted, with what we are potentially going to see. We don't know, but if that does happen, then that is a concern. But I think that's the key message there for our listeners, is that we should be compassionate. We should work out, how did this happen in the first place, rather than arguing with each other. How did we get here, and how can we stop this from happening again, which is the thing that we really need to address.
100%, Bobby. And I think there's an opportunity. Let's see it as an opportunity to, without sounding too cliched, to actually make the world a better place. I mean, finishing up, when we talk about health, the World Health Organization, and I don't agree with everything that they have done, but none of us are black and white. We have shades of gray. We don't always get everything right in our own lives. Okay, so you should look at the whole picture and look at the net effect of a person or an institution on society. But I love their definition of health, which is a state of complete mental, physical, and social well-being, not merely the absence of disease and infirmity. So we talk about health. If we understand that definition, we can then branch off into the root causes. Because what does social well-being actually mean? It doesn't. Social well-being is not going to be improved by giving people pills. It's about understanding the conditions in which people work and grow, about relationships even, most stress, for example, comes usually from either work or relationships.
Yeah.
So let's all think about that, right? Even relationships with our partners, with our friends, these are improving those and thinking how we can improve those, and even doing a job that you enjoy, that you're good at and that gives back to society is going to give you more fulfillment than anything else. And many people aren't doing that because we've lost, I think, the culture in many ways in society has been influenced by these very powerful entities. We may not be aware of it, but these very powerful entities that are anti-human in the way that they carry out their business. It's extracting money through deceit and lying and whatever else. And if they have so much power and control over our lives, some of that is going to seep into the culture of people.
Yeah.
So let's just go back to thinking about what does it mean to be human, but also acting from a position of values, honesty, integrity, and courage. We need courage as well. We need to stand up and speak the truth, because if we don't, not speaking the truth is going to cause us more harm in the long term.
I couldn't agree more. And you're totally, absolutely right. Health is more than just the absence of disease. Just because we've got somebody that doesn't have a physical illness in front of them, they could still be leading a really poor quality of life, not be happy, not be getting fulfillment. And, sometimes we were actually filming a consultation recently, and really interesting guy, middle-aged, pre-diabetic, kind of being told, look, you're going down the route of potential heart disease. Got lots of problems with his relationships at home, not happy with his job. And the first thing I said to him was, look, how fulfilled are you in your current life at the moment? And he just said, I actually got no purpose. I go to a job I don't enjoy. I've got problems at home that aren't being addressed. I'm not happy. I've got these insecurities, etc. So we really just actually focused on, okay, let's look at this together. How can we address this? How can I support you with this? And he came in for a follow-up, and we gave him some other dietary recommendations around his blood sugars, of course, etc. And a lot of stuff you've been talking about. And he was literally a different person. I mean, you could just see it. As soon as he came in, he looked a totally different person. And a lot of that was just basic stuff that you've just been talking about, going back to the basics of what it means to be human. And I think that's what we have a responsibility to do, that for our friends and our family, and to help people be compassionate to each other, listen to other people's problems. How can we support them together rather than, like you said, zooming in on just ourselves?
Absolutely. And I think that's crucial, because you can improve your own lifestyle very easily, but we don't live in cocoons. And even if we help ourselves and do something and get better, which is great, that then needs to be disseminated to people around us. And again, if people around us are suffering, we're going to suffer as well. So we have to think things, I think, more from a collective perspective rather than an individual one. And if we think collectively, we're helping ourselves individually as well.
Yeah.
Rather than focusing on the individual and ignoring the collective.
Exactly. Some very powerful messages. I did want to just ask a little bit more around cholesterol. I know we've been there, just coming back a little bit. I know we spoke about LDL, which has been called bad cholesterol. Yeah. And so a lot of people know this is my bad cholesterol. And obviously you've highlighted already that we do need cholesterol for lots of reasons. You've highlighted the immune system, you know, we need it to make hormones, vitamin D, etc. There's lots of functions of cholesterol. If somebody comes in to you and they've got their blood test and it shows their total cholesterol, their LDL and their HDL, which is referred to as the good cholesterol, how much significance are you putting on that?
Not as much as I think many other people would. So what I do is I see it as a marker in the overall picture. So you always treat the whole patient, not a lab number, first and foremost. So what I often do is I look at that profile. For me, the two most important things in the cholesterol profile that are really a marker of insulin resistance are the triglycerides and the HDL, so-called good cholesterol and triglycerides, which is another part of the cholesterol profile, the fats in the blood. And what you want ideally, so a very simple thing to try and remember, is you want your triglycerides to be less than your HDL. And if you're in that place, actually your cholesterol profile is probably the healthiest it can be, and you are doing the best you can from an insulin resistance perspective, so that's great. What I then do normally is, when I have a discussion with a patient, is I use something called a risk calculator called Q-risk calculator. And what that does is quite slightly crude, but pretty generalizable, is that you can put different things into the calculator, including age, blood pressure, family history, whatever else, and cholesterol profile. And in fact, in that calculator, they use a total cholesterol and the HDL.
Okay.
Which is another marker of insulin resistance. Not as good as triglycerides and HDL, but it's pretty decent. And then what happens, it comes up with a risk of heart attack or stroke in the next 10 years. Because I think empowering people with the numbers involved as well is useful, because many people come in, they've been scared to death because cholesterol is high, just from a lab number, right? No context. And they suddenly think, oh my God, I'm going to have a heart attack or stroke. So often I'll say to the patient, so listen, you're worried here and I want to have a proper chat with you about this. Can I ask you, for example, what level of risk would worry you if I said to you a percentage chance of you, if we leave you as you are, having a heart attack in the next 10 years? Or what do you think might be happening from what you've been told? Oh, it might be, I'm thinking I've got a 50 or 60% chance. So, well, I'm pleased to tell you your chance is actually only about 4% right now, okay? And I'll say, compared to someone of your age, it might be slightly higher or lower, but that straight away calms them down, because we're here to alleviate fears. Okay, what can we do to ensure that it stays that way or it lowers or whatever else? And then I go into the lifestyle stuff. Right. So I would only see cholesterol as a marker of the overall picture, and I never treat a cholesterol alone. You know, one of my colleagues and friends, who's a cardiologist, very eminent cardiologist in America, in University of California, San Francisco, her name's Professor Rita Redberg. She's also the editor of the journal JAMA Internal Medicine. So, you know, very high integrity. And in an Australian documentary, she uses this line, which is great. She says, cholesterol is just a lab number. Who cares about lowering cholesterol unless it actually benefits the patient? So in relation to that, I will then talk about, if patient asks me, well, is there anything else I can do, doc, to lower it? I said, well, we're not here to lower your cholesterol. We're here to reduce your risk. And in that process, your cholesterol profile might improve by improving the triglycerides and HDL if you cut the refined carbs, you know, if you have extra virgin olive oil and, you know, all those sorts of things. That's how I approach it with my patients.
It makes perfect sense.
Yeah. And sorry, Bobby, the other thing I would say is, one of the things I think is really useful that we still need to keep stressing to patients, you know, you mentioned this great story of this chap that improved his lifestyle and felt better, is that the impact of lifestyle and health is actually quite rapid. You know, I tell people that if you do this, what I'm asking you to do, just do it for me. Can you do it for a month? Do you think you can manage? Oh, cutting out pizza. Okay, doc, I'll do it for a month. They come back and think, wow, I'm feeling better. My markers have improved. And that's a great place to start. It doesn't necessarily mean they're going to sustain it, because they need other things. And of course, if the food environment is working against you, which it is constantly, you're more likely to fall off the wagon. So one of the reasons why people don't necessarily adhere to improving their diet for long periods of time, or many people fall off the wagon, is we're not focusing on the environment that they are living in, which makes it harder for them to sustain it. So that's where policy changes come in.
Right. And you meant, just going back to the blood test, actually, I think what's quite nice for patients is when you contextualize, like you said, in the bigger picture of their life, drawing all of that together, then it becomes more relevant. But also, I guess, some of the markers you can use then as a reference point so that you know how they're getting on. So with this guy, for example, we looked at HbA1c, which for our listeners is a marker of basically blood sugar levels. And it'd gone down from 41 to 38 in about 2 months. So he did really well in 2 months. He was kind of coming out of where they were saying he borderline about to go into pre-diabetic, which was really interesting. So like you said, these things can change quick. And it does, I think, when a patient sees the numbers change, if the number's relevant, it's that kind of like, I've got this. I'm going to keep doing this. I'm going to follow what you've said. I'm going to keep working on it, because people like data, don't they? They like to see a number in front of them. So that's, I guess, how you can harness that to your benefit too. Yeah,
absolutely. I think it's a great motivating factor. I think it's about also being judicious, because, of course, we can organize lots of tests for patients that are often unnecessary, and you don't. So one of the things I also teach my medical students, and you know, when I was a doctor in training as well, I remember this, is that it's really important to, you know, don't organize a test unless it's going to change the management plan.
I think that's
because there's a lot of unnecessary tests people doing. It creates unnecessary anxiety, and you don't know what to do with the result, and like, well, you know, I'm not sure how reliable this is, and so that's another rule of thumb. I think it's important to remember: only organize a test if the result will change what you do.
I think that's a really good point. Really good point. Same even at CNM. There are obviously lots of testing options available out there, very comprehensive panels, but like you said, we always say, unless it's going to change your management, then it's a waste of money. It's a waste of time.
Absolutely.
You've obviously highlighted that cardiovascular disease is an inflammatory disease. It's driven by inflammation, which I think is a really good point.
Yeah.
Do you therefore look for markers of inflammation on blood? Is that one of the markers you look for?
You can do. I mean, a lot of this is based upon very expensive tests that through sort of lab work is not necessarily easily available. These what we call pro-inflammatory cytokines that are linked to chronic inflammatory heart disease that you wouldn't routinely do. The one test you can do, which is quite useful, is high sensitivity CRP. But again, I wouldn't just look at that in isolation.
Yeah.
I think if you focus on the simple things are actually cheaper than the NHS, because I want people also to be able to improve their lives. And of course, if we're doing this across the population and through medical practice, if we've got simple, safe, cheap, easy tests to get that can sort out most of the problems, and why go down the expensive route?
That's true.
So, I think the most important, there are markers of metabolic health, which also covers likely root causes behind things like has a role in cancer, in dementia as well, are essentially looking at your blood pressure, your HbA1c, which you've mentioned already, Bobby, the triglycerides and HDL, and then waist circumference.
Okay.
So, blood pressure, you can even get a simple blood pressure machine from Boots for 40 quid and have it for life and see what your blood pressure is. And the HbA1c and the cholesterol profile is a simple blood test. And then you've got waist circumference, just a tape measure. So those are the metabolic health markers. In fact, if you focus on those, in fact, the improving all of those can happen very rapidly just from lifestyle changes, just from changing diet, to be honest.
And on that note, in terms of diet, is there a particular kind of dietary model that you recommend in terms of preventing and also kind of working with cardiovascular disease?
Yeah, so I think the low-hanging fruit. So every patient has different values and preferences when it comes to food. They have different cultures. Some of them may be vegetarian or vegan. Some of them may be meat eaters. So I think the low-hanging fruit stuff, which applies to everybody, is first of all eliminate ultra-processed food. So what I normally do is I look at every patient is going to have different preferences and values when it comes to food choices, different cultures. Some people may be vegetarian, some people may be vegan, some people may be pescatarian, some people may enjoy eating meat. The low-hanging fruit, first and foremost, is I tell them to eliminate ultra-processed food, which actually is a big problem in this country. Half of the British diet now, the calorie consumption comes from ultra-processed food. So it comes out of the packet, has 5 more ingredients, usually with additives and preservatives. Don't eat it. And that can apply to stuff from, low-fat yogurts to packaged bread, even brown bread, right? Ultra-processed, just avoid it. Then after that, I say, minimize your low-quality carbohydrates. So these are carbs that lack fiber, refined carbs. So your breads, your pastas, rice and potatoes, certainly minimize that. Doesn't mean you can, I would say, it depends where you're starting from. But if people are going to do this for the first sort of 4 to 6 weeks, I say go cold turkey on it just to see what best you can achieve. And then I say follow an 80-20 rule if you can. So, it means you can still have treats every so often, ice cream, pizzas, whatever. But rather than being completely, and some people prefer that they want to stay off that. They feel so good just when they cut that out, then they never go back to it. But I'd say at least do 80% of the time where you're eating whole unprocessed foods, Bobby. That's the key. Yeah. Whether it's predominantly meat or veggies or vegan or whatever else. My only concern I do find, and I understand where people come from an ethical perspective on the vegan stuff, is that you can't really have a vegan diet without taking supplements. And that's fine if that's what you need to do. But I think any diet that requires supplements isn't a nutritious diet. So I think these people need to understand that. Yeah. Because there's a lot of greenwashing and there's a huge sort of ultra-processed vegan diet, ultra-processed food, vegan diet movement out there as well. And that concerns me a wee bit. So if we just stick to the ultra-processed foods, getting rid of that, minimizing low-quality carbs, I think you're already in a much better place.
I think a lot of people do think vegan equals healthy. I think there is that assumption, and people say to me, I don't eat dairy, for example, and people will say, oh, we'll take you to a vegan restaurant, it'll be really healthy and it's dairy free. And then we go in there and it's like fast food vegan and, it's all really highly processed soya-based burgers or whatever it is. And I'm thinking this is not really for me.
Absolutely.
So I think you've highlighted a good point, which is definitely that vegan doesn't equal healthy. And And I just wanted to ask you, actually, Mediterranean diet, is that kind of a model that you would recommend for your clients? For your patients?
I think traditional Mediterranean diet obviously has evolved over time. And people come back to me and say, hold on a minute, you're advocating for Mediterranean diet, but you're saying no bread and pasta and stuff like that. I think to answer that, I think one is the information has evolved a lot in terms of the effect of refined carbohydrates on blood sugar and insulin resistance. I think that the type of bread we're eating now is not the same bread that they were eating in southern Italy, for example, in the 50s and 60s. So there's all of that you've got to add to the equation. There were no ultra-processed foods. So they never got into a situation where they were already metabolically unhealthy, and then they were exacerbating it by having lots of bread and pasta. So, but in the modern day, I would say, what are the components of the Mediterranean diet that are thought to, based upon information we have in terms of evidence from observational studies and even from randomized controlled trials? So the key components of the Mediterranean diet that are thought to be beneficial for health are things like, the omega-3 fats from oily fish, nuts and seeds, extra good quality extra virgin olive oil. I focus on making sure you get good nutrition, so you get enough protein, you get all your vitamins, maybe meat and dairy if you eat dairy, low sugar fruits, vegetables, that kind of thing, and then minimizing the low quality carbohydrates.
That makes sense.
And I think that's, for me, that's where, from a heart disease perspective, the evidence seems to show the best benefit.
Right. Okay.
Yeah.
And you mentioned about, for example, cutting out rice. So would you, for example, recommend going for like brown rice, or would you sort of go rice generally?
So the interesting about the brown rice stuff, I looked at this, people look this up, so people go for brown rice because they think it has a lot more fiber. There's hardly any difference at all. Say white rice has 2 grams of fiber per 100 grams, brown rice has 3. And it's nonsense.
Yeah.
So if you're going to eliminate rice, I'd eliminate all rice.
For all of it. Yeah. Right. Makes sense. Makes perfect sense. What are your thoughts on artificial sweeteners?
I think I think there isn't a lot of evidence of harm, but I think the problem with artificial sweeteners is, and I'm somebody that's been a big advocate on sugar reduction policies and highlighting the harms of excess sugar, is that it stops. One of the ways of quitting sugar is to go cold turkey on things that are going to be sweet, so that your palate changes and you stop the cravings. The issue with artificial sweeteners is it doesn't help stop the cravings. So I think intrinsically they're not particularly harmful from data we know at the moment, but I would say just avoid them to start with anyway.
That makes perfect sense. And what are your thoughts on things like alcohol in terms of sort of cardiovascular disease? Yeah,
so again, there's a lot of mixed data on that. I think that in moderation, alcohol doesn't seem to have a big problem. It may be protective, and if it is protective, it's probably only specific red wines and the procyanidin, the anti-inflammatory compounds in those wines, that are likely to be beneficial. One of the resources people can look up, or they can look up a book by, it's probably one of the world, if not the world leading researcher on wine and its benefit to health, in particular red wine, is Professor Roger Corder at Queen Mary University, and he wrote a book called The Wine Diet. Now, I've got a bias, okay? I've got to admit I've got a bias here. I love red wine. So I don't think I'm going to be very objective in wine.
At least you've declared that.
Yeah, I do like red wine. I'm not being paid by any wine company or anything like that, just to be open and honest. So, but I think if people are going to have red wine, then have it with meals. I think there's probably a good argument to be made that one of the benefits of the Mediterranean diet is the synergy of foods. So you're having oily fish with extra virgin olive oil and a glass of red wine with it. I think that together probably creates an overall net benefit to your body, your mental, but again, in moderation, glass of red wine with meals. Certainly, if you look at certain populations around the world that have followed that kind of dietary pattern, I think there probably is some benefit. Right. But you don't need it.
Yeah.
And one of the things Roger Corder points out in his book, which is quite interesting if people don't want to drink red wine, the level of procyanidins, these so-called anti-inflammatory compounds that are thought to be beneficial for the heart, are actually quite potent in pomegranate.
Yes, yeah.
So I actually have, every morning, I have pomegranate.
Do you?
Actually, yeah, I do.
It's a great way to start the day.
Yeah.
That's amazing. I feel like every plan I write for a patient has got pomegranates in there, for whatever it is. It's a great one. Okay, that all makes perfect sense. And don't worry, we'll allow your bias on this occasion. I did want to come back to statins, sort of following on from the link with heart disease and what we've spoken about. We've obviously started this conversation. And one of the things I find interesting with statins is the compliance long-term for patients taking statins actually being quite low, if I'm not mistaken.
Yes, very true. So about 50% and even more patients within a couple of years of taking statins, even people with heart disease, will stop taking it. And surveys suggest they stop taking it because they get side effects. In particular, they're not life-threatening, let's be honest, but quality of life limiting side effects. So fatigue, muscle pain are the most common. And it's very controversial about how prevalent this really is. In my own experience, I reckon probably, and looking at the data, it's probably at least 1 in 5 people at some point taking statins will develop side effects related to it. But that then becomes a good opportunity for a conversation about what benefit the statin giving you, safety around stopping it, and then other lifestyle changes that they can implement.
Makes sense.
Yeah.
I think the muscle pain is a really big one because a lot of people, I'm not sure, is this something that a doctor would normally say? Like if a GP, for example, was to give a statin, would they normally tell a patient about muscle pain, or is that not normally part of the
It's not normally
speech?
part of the conversation because sometimes if you tell patients about side effects, they can start thinking that they're getting a side effect when it's not the pill. So I think because it's not a so-called serious side effect, I mean, it's debatable whether or not you mention it. I don't tend to be in a position often where I'm starting a statin on people. I'm often, people are coming to have informed conversations about the statin. And then what I will do is if we think there's a side effect, and it can be even people feeling that they've got brain fog or whatever else, then we do a trial on a reduced dose or stopping the statin completely for a few weeks. I think the good news about statins is a lot of these side effects that are, interfere with the quality of life are rapidly reversible within a few weeks of either lowering the dose or stopping the drug.
Right.
And that's how, I do it in a way that tells them, okay, first of all, why are they on the statin? What benefit are they getting?
Yeah.
Reassuring them that if we stop it, the risk of harm is very, very low. And then they make a decision how they want to continue after that.
Informed consent.
Absolutely.
One of the mechanisms, I believe, and again, please do correct me if I'm wrong here, is that statins reduce the levels of coenzyme Q10, CoQ10. So this is kind of a hot topic, certainly in the nutrition world, that if somebody is taking a statin and they want to still take a statin, that using CoQ10 can reduce side effects. What are your thoughts on that?
No, I think that's fine. I think that's it's a good question. So the options are, well, either stop it and feel better and don't need it anymore, or take CoQ10, which is very safe. Yeah. And they might find their energy levels and muscle pain decreases. So again, I have no issue with that at all. I think that's reasonable.
I guess you're in the position where you can have that conversation with your patient, like you said, where you can lay it out in front of them. And I imagine, being frank, that a lot of patients will probably make that decision that they don't want to be taking it and they don't feel as though that's appropriate for them, based on the information that you've given them. So I suppose you probably don't that often need to go down that route. And of course, every practitioner has a preference anyway. But I think it's a really good point to make, actually. And I've seen patients, especially from my osteopathic side, where people come in and it's very vague muscle pain, isn't it? It's not somebody coming in going, oh, I've just twisted my back and my back's hurting. It's sort of, my legs are aching, my back's aching, my shoulders. It's that sort of vagueness that I think's what I've picked up on. Again, please do correct me here, that seems to be associated with statin related muscle pain.
It's very common, actually, to be honest. And I think for, the reason I got down the statin route and looking into a lot of detail, one is because there was a huge misdirected focus and obsession over prescription of statins, distracting from things like insulin resistance. That's one reason. One, the side effect profile from what I was seeing clinically, what my own clinical intuition and experience seemed to not fit with what the published data was telling us about the prevalence of these side effects. If doctors are not aware of a potential diagnosis in terms of a particular side effect as a part of the differential diagnosis, they will always miss it.
Yeah.
And that also comes into the discussion, potentially around vaccine harms, is if there's a list of potential side effects that doctors are not made aware of, if a patient comes in with a problem and they don't think that is even part of the differential diagnosis as a cause, they'll always miss it. Yeah. And that's not good.
Yeah. And going on that topic of the vaccine, I guess in terms of side effects as well, one argument that has been thrown out there is also that because this is such a new thing in relative terms,
Yes.
we still don't know the long-term effects.
Yeah, that's true. I think that's a fair point. We can say that of many drugs, to be honest. I think one of the things is, and it was understandable maybe to some degree at the time because it was turned over very rapidly. Normally, when it comes to vaccine development, the period of time it takes before they're rolled out for safety checks are usually 5 to 10 years. We didn't really have that opportunity this time, which increases the likelihood of things going wrong.
Makes complete sense.
Yeah.
Well, everything you have said makes complete sense. And I have to say, I'm a huge admirer of what you stand for, what you represent, and that you use your voice very powerfully. And I think it's very important that people feel as though they are informed, that they are able to make the correct decisions, and that, you know, you're making this information available to them. So I want to thank you first and foremost for coming on the podcast. I did just want to ask you as a final question, or a final point really, just to summarize what the key take homes are that you would like to give to the listeners from this podcast.
I think the key thing that we're facing, the biggest issue right now in healthcare, to quote Marcia Angel, the former editor of the New England Journal of Medicine, the battle we've got with our health, with population health, is one of truth versus money. I think we need to make sure that we focus on the root cause of the problem rather than focus on the downstream effects, because we won't get very far. And the real root cause of the problem, unfortunately, in society right now is unchecked power of big corporations that are there purely to look after their own profit, not to look after your health. And in fact, will often deceive you in the process of you believing that the information you're receiving is going to improve your health. So what we need is a collective movement to focus on the legal entity that is the corporation, that then will improve societal health and make us live in a better world and give a better world to our children. That's what I would say is the most important take-home message from this. You know, an entity, I've used this, and it's provocative, and I've used this in my lectures, but, you know, it isn't without basis. The man behind, or certainly one of the most influential figures behind the original definition of psychopath, was a forensic psychologist called Dr. Robert Hare. And in the book, The Corporation, written by Joel Buchan, law professor, he actually lays out that the entity, not the people within it, because, you know, the system, I think, encourages good people to do bad things. The institution, that is the corporation, functions in an anti-human way that is akin to defining what a psychopath is. So that's the battle we face. Yeah. So it's about being human and understanding what we're actually really up against at the root cause of the problems that are affecting our health. And if we focus on that, then we'll be in a better place.
That was beautifully said. And I'm going to leave the podcast on that as a beautiful way to end. Thank you so much for your time. And lovely to spend some time with you.
Thank you, Bobby.
Thanks for listening. And don't forget to subscribe to our YouTube channel so you never miss a future episode.